Good afternoon. Welcome to the Assembly Committee on Health and Human Services. I'd like to welcome everyone here in Carson City and Las Vegas. We do have an overflow room and our members there and anyone joining us online. Secretary, would you please call roll?
Assembly members Dahlia. Here. Edgeworth. Here. Gonzalez. Here. Goulding. Here. Gray. Here. Hathan. Here. Hibbets. Here. Hunt. Here. Jackson. Here. Koenig. Here. Nadeem. Present. Wen. Here. Ortlicker. Chair Brown May.
Thank you. I am here. When Assemblymember Ornlicker arrives, please mark him present as he is presenting a bill in another committee currently. To our guests, a few housekeeping reminders. Please silence your electronic devices. If you want to testify, sign in at the table by the door. Members of the public may provide testimony on a bill either in person or by telephone. To do so, you would call 888-475-4499 and then when prompted, enter the meeting ID at 882-2054-2738 and then press pound. I will remind you again as we get into public comment later in this session. A meeting agenda and committee information is available on Nellis, which can be accessed through the legislative website. It's also available on YouTube. Public comment we will do at the end of today's meeting. Please remember respect for everyone who is presenting today, even if we may have an alternate opinion. No signs of disrespect or inattention will be tolerated. We have 3 bills on our agenda today. So we have a very robust meeting ahead of us. We are going to take them a little bit out of order, and so we are going to begin with opening our bill hearing for Assembly Bill 326, which revises provisions relating to the designation of hospitals as centers for the treatment of trauma. We will invite our member, Assembly Member Koenig, to the table alongside his team to present. Please remember to state and spell your name for the record, and you may begin your presentation whenever you are ready.
Thank you, Chair, and the Health and Human Services Committee for hearing Bill number AB 326. My name is Greg Koenig. I represent KOE-NIG. I represent Assembly District 38. And I have been told that I'm supposed to smile and pretend that I'm happy to be here. So I will do better. So this last session, I carried a bill for the Rural Hospital Association, and it was the hearing went so well that at the end of the hearing, everybody on the committee wanted to co-sign it. So I'm not expecting that today. But, most of my bills have to do with helping my rural constituents and see if we can make life easier for the rurals, because I do have from Fallon to Tonopah, which is a lot more jackrabbits than people. But so I got with Blaine and we had a discussion on, hey, what can you do to help my constituents this session? And this is what we came up with. So I really like the idea, but I'm going to turn it over to Blaine to go over the bill and answer questions. And we have a phone a friend here also, and we will turn the time over to Blaine at this point.
Thank you, Chair and members of the committee. Blaine Osborne, B-L-A-Y-N-E, Osborne, O-S-B-O-R-N, for the record, President of Nevada Rural Hospital Partners. Thank you, Assemblyman Koenig, for working on this bill with us. In my opinion, AB 326 is an infrastructure bill, one that will spur investment in advanced trauma life support training across rural Nevada, and one that will benefit everybody, including higher designated trauma facilities, but most importantly, the patients, who, as many of you know in rural Nevada, often miss out on that first golden hour in trauma care due to the vast distances across the state. We have a short slide presentation for you. And so very quickly, AB 326 requires the State Board of Health to provide for the designation of trauma levels 1 through 4. Currently, Nevada only recognizes trauma levels 1 through 3. You'll also see an existing law in NRS 450B.237, where the Board of Health has the ability to do regulations establishing the standards for those designations. And our intent is not to change anything with Southern Nevada Health District and their approval process. This bill does require an application to the Administrator DPVH, and we've put up safeguards, we hope, the needs assessment. You'll see in the bill, we've tried to make it very clear that trauma level 4, that designation is not a stepping stone for a facility to start with a 4 and then move up to a higher level designation automatically or anything like that. They would still be required to go through the same comprehensive needs assessment that they have to do in order to get that initial designation. AB 326 also does not change any existing designated trauma centers or their requirements. So what is a trauma level 4 designation? Level 4 Trauma Center has demonstrated an ability to provide advanced trauma life support prior to the transfer of patients to a higher level trauma center, provides evaluation, stabilization, and diagnostic capabilities for injured patients. You can see what some of the elements of a level 4 designation include: basic emergency department facilities implementing ATLS, 24-hour lab coverage, available trauma nurses and physicians available upon patient arrival. They may provide surgery and critical care services if available. They've developed transfer agreements for patients needing higher levels of trauma care. And they have incorporated a comprehensive quality assessment program and are involved in prevention and referral efforts in their communities. Just a quick reminder for you on what a critical access hospital is. We have 13 of them in the state. You'll see that's our map on the right. And you can see the distance is how far spread out all the critical access hospitals are across the state. To be a critical access hospital, you are limited to no more than 25 inpatient beds. You have to provide emergency services 24/7, 365, including abiding by EMTALA. You have to have a plan for emergency medical services and an inpatient annual average of 96 hours. There are certain staffing requirements, transfer agreements that you must have, and distinct parts are allowable, including psych, rehab, and long-term care. And in so doing, Medicare reimburses these facilities at their costs. So 34 states recognize trauma level 4 already. And the thing that really struck me with this map is that I thought it was really telling that almost every state west of the Mississippi River has already done trauma level 4, with the exception of Louisiana, Nevada, and I guess we can throw Hawaii in as well. And here you can see the current trauma designations in Nevada. That might be kind of small, but you will see we only have one level 1 trauma center in the state. That is University Medical Center in the south. We have 2 level 2 trauma centers, Renown and Sunrise, and we have 2 level 3 trauma centers. And I think if you're looking at this map and wondering, especially in northern Nevada where the trauma system is, I think that's a good question, because I would argue that we don't have much of a system if we only have one designated facility. But AB 326 has the potential to change that, creating a real comprehensive network to improve trauma care for patients in rural Nevada, where the Trauma 4 designated facilities will have worked with levels 1, 2, and 3 on standardized protocols, collaborative treatment and transfer guidelines, the quality assessment programs, and where they can improve stabilization and reduce transfer times for patients. And so here you can see on this map what a potential for level 4 trauma centers could look like. And I just wanted to note too, although we have 13 critical access hospitals in the state, in no way do I ever envision all 13 of those critical access hospitals ever pursuing a level 4 designation. In fact, I think it would be less than half of our member hospitals that ever pursue it. You can see, though, we could spread out across rural Nevada and cover a lot more of that distance with better trauma care. With that, it's my pleasure to turn it over to Jeff Prater, Administrator of Carson Valley Health.
Good afternoon. I'm Jeff Prater, Jeffprater, and for the past 7 years, I've had the pleasure of serving as the CEO of Carson Valley Health, which is a 25-bed critical access hospital located in Gardnerville, Nevada. So I want to thank you, Madam Chair, and the committee for this opportunity to speak with you today about this. For the past 15 years, I've served as the CEO and/or administrator for critical access hospitals. Prior to serving at Carson Valley Health, I was in the state of Alaska, where there I had the opportunity to start a level 4 trauma designation hospital in Barrow, Alaska. Barrow, Alaska is the northernmost town in the United States, literally a rock's throw from the Arctic Ocean, in a town of around 5,000 people. Also served at an existing level 4 trauma designated hospital in Sitka, Alaska, and was appointed by the Alaska governor to the state trauma board. Last, while serving as a hospital corpsman in the United States Navy, I was also an EMT and a pre-hospital trauma life support instructor. So just want to give a little bit of background as it pertains to what I want to talk about today. Just a few benefits of and the purpose of a critical access hospital with a level 4 trauma designation is to evaluate and stabilize and then to make a decision whether or not to transfer that patient to our high level of care. Decrease transfer times to higher levels of care, and according to the Journal of Acute Care Surgery, it decreases mortality, provides timely and structured care, provides 24/7 on-site care with diagnostic capabilities, continuous staff education and review of process, provides community outreach and education, enhances the state trauma system, and strengthens the partnership with local EMS as well. But what is it not, I think, is another question. What it's not is a barrier to access to the level of care. In my 15 years as a critical access hospital CEO, I've never seen or heard from a stakeholder that a level 4 trauma designated hospital was a barrier or a delay in care or created one. Nor was it ever required for any sort of EMS or life flight of that, if you will, to have to stop unnecessarily on their way to a higher level of care with that patient. For example, when I was in Barrow, Alaska, we serviced an area of about 95,000 square miles, and never, when a life flight would come to another village within the North Slope, did we ever ask or were they required to stop at our facility on their way to a higher level of care. And that would be the same here. Also in Sitka, Alaska, we had over 35,000 square miles of coverage, and it as well was it ever necessary, unless it was to stabilize a patient on their way to a higher level of care. And that could have been because of blood products or something else, so that patient survived on their way to that higher level of care. And I want to get to a quick story here in a second. But since mid-2018, Carson Valley Health has delivered care consistent with that of a designated level 4 trauma hospital and its standards, which is to say we internally activate a trauma team. We have a trauma director, which is a board-certified emergency room physician, a designated trauma nurse coordinator. We have nursing staff that are TNCC or Trauma Nurse Corps course trained. We have an active trauma committee that reviews our cases and have established written protocols utilizing advanced trauma life support. I think it's important to note that allowing level 4 designation of a critical access hospital does not mean that suddenly, all of a sudden, all these trauma patients are going to start coming to our facilities. The truth is, however, they're already coming. They're already coming to our facilities today, and that's demonstrated in Nevada's annual trauma report every year. For example, in 2024 alone, Carson Valley Health received 233 traumas, and of those, only 82 were presented via an ambulance, and 151 of those arrived via their own personal vehicle, which is pretty typical in a rural area. Not in a rural area, typically you will see those patients presenting in that manner. Of those 82 arriving by ambulance, only 37 or less than a week had to be then transferred again outside of our facility. We have a very highly trained trauma team with board-certified ER physicians and TNCC trained staff. And during that time period, since 2018, we were also able to decrease our transfer times once a patient arrived by 1 hour. So basically decreasing, the time for transfer to a higher level of care. With that, I was asked to tell a couple of personal anecdotes about Level 4 Trauma Center and my experiences. When I was in Sitka, Alaska, we, as a Level 4 Trauma Center, we activated trauma when we heard that there was a bear mauling on another island. During that time period, we were able to call in our trauma team, and in our hospital itself, it was only a 3-bed emergency room. So we had to clear the entire emergency room out to make room for all the staff that had to arrive for that trauma. Now, our facility was also on an island that had the runway right next to the facility. So when the bear mauling was actually called and it was notified, the United States Coast Guard had to then go out and retrieve the patient. Now, during that time, it took an hour and a half before the Coast Guard was actually notified because of the distance of that patient and where they were located. There was no reception, which is pretty typical of even rural Nevada, when you get out in certain areas and not having reception and having a long time before there was even a recovery. Once the Coast Guard got him to us, this patient, well, one could ask, well, why would that patient not just go straight to a level 1 trauma center, whether that be in Anchorage or whether that be in Seattle? We knew, especially given the runway was right there, and the fixed-wing aircraft was there to take them. The problem was this patient, and by the way, I'm not violating HIPAA. This patient, this is in the news, and you can read it if you want to. This patient actually had lost a lot of blood, and they needed to receive some blood products so that they could make it to their final destination at that level 1 trauma center. So we were able to stabilize that patient and get them to their final destination. This patient had multiple fractures of the femur. They had both femurs, tib fib fractures. There was actually the ulnar radius of both hands from defensive wounds, and there were other wounds with this patient, and that actually caused them to lose a significant amount of blood. The last story I wanted to mention was a personal one, and this was about a year ago, and this is very indicative of rural areas in Nevada. I was on a cycling training ride, if you will, with a group of folks. I was coming down the Pacific Grade, and this was on a bicycle, not a motorcycle, and it was determined by my Garmin that I actually was going 34 miles an hour on my cycle when I hit the ground. And coming down the Pacific Grade, went tumbling. It took, for a long story very short, it took them an hour just to get me to my truck. On my way to my truck, I started feeling, not myself. I started feeling a little different, but I was with a team of people who didn't know me. So they didn't understand or see my face or understand how I communicate to know that there was something not appropriate with how I was communicating. Unfortunately, or fortunately, I did get in my vehicle and I drove myself to Carson Valley Health, because on my way there, I started to realize that something was not 100%. And I tell you this story because it's very indicative of the 151 patients, or the other 150 patients, that came in via their personal own vehicle and walked in. Once they triaged me, they realized quickly, because our team is trained and TNCC trained, we're able to recognize by the mechanism of injury and the fact that I had road rash all over me, that they activated trauma activation at that moment. I was lucky enough that I walked away with just a bruised lung and a lot of road rash. But it's indicative, as I said, of what a level 4 trauma center sees and what is presented into a trauma center, or a critical access hospital. They are typically walking in from ground level falls and things of that nature. So I want to thank you for your time.
So at this point, if it's okay with the chair, we will take some questions from the committee. Greg Koenig.
Thank you for your presentation. Thank you. Members, you should all have the bill in front of you. We do have a couple of questions. We'll start with Assemblymember Nadeem.
Thank you, Madam Chair. Thank you for the presentation. So the hospital is already has the trauma center, right? So can you guide us through that to make it a level 4 trauma center? What is actually needed? What are the upgrades are needed?
Thank you, Assemblymember Deem. Through you, Chair, to the...
You can go direct. Thank you.
Blaine Osborne, Nevada Rural Hospital Partners, for the record. No, currently none of the critical access hospitals have any trauma center designations yet. As far as the regulations and standards they would have to meet, AB 326 allows that to be left up to the Nevada State Board of Health to determine the proper procedures that they will have to go to in order to earn that designation.
Okay, thank you.
Apparently, we don't have a lot of questions today, but I do have one. Knowing that we have great hospital care, so as a cyclist, often you're on a road by yourself, right? And you're in rural areas which don't often have services. I'm disappointed in your team, I will say, that they did not know you and allowed you to get in your vehicle and drive away. So we'll have to ride with different people in the future. But understanding that the team at the hospital when you arrived was prepared to be able to assess you for trauma, I'm wondering if you could walk us through just a little bit about what is the cost associated with becoming a level 4 trauma center, and what are the benefits to the hospital system as well as to the patient?
Madam Chair, Jeff Prater for the record. So the training itself, the cost to the facility is the cost of the training and the cost of the medical director, the cost of the time for a particular nurse to be that person who takes care of our trauma information, and the time for the committees to convene within the facility and then to submit that information to the trauma registry in the state. So those are the costs associated with that. In addition, any training that we pay for our nursing staff to be TNCC trained. I apologize, I don't have the cost of that training on the top of my head. I apologize, I'm missing the rest of the other question. The benefits to the patient is really that, that quick care that you get, myself included, as you see as I walk in, which is very typical of a rural facility. You typically don't get a heads up when a trauma patient comes into a critical access hospital like you would in an urban area. You usually know how many minutes they're out. But in this case, you don't get that, but you do have that rapid assessment of that patient by those trained individuals, and they're able to assess that patient and get the care and call the team quickly, which is why we were able to reduce that transfer time by an hour over that time period, because we do call those folks there.
Thank you. We have another question from Assemblymember Gray.
And I'm sorry, you may have actually covered this. I was distracted for a few minutes. Are there any other states that have implemented the level 4, and how have they gone?
Thank you, Assemblymember Gray. Great question. Blaine Osborne, Nevada Rural Hospital Partners, for the record. Yes, as you can see on the map, 34 other states recognize trauma level 4 currently. And I think, just to kind of piggyback on the last question from the chair, I think one of the benefits is in forcing the hospitals to work together as a system, in that you're getting those level 4 trauma centers coordinating with the higher level designated facilities. Currently, that doesn't happen in the same way as it would with a focus on the designation.
Quick follow-on, ma'am? Sure. Okay, so the 34 other hospital settings, I didn't realize there were that many now. What problems have they experienced?
Thank you, Assemblymember Gray. To be honest with you, I don't know the answer to that. I think this has been a long-standing designation, and many of these states have implemented trauma level 4. I was surprised in doing the research on this bill that just how many level 4 designated facilities some of these states have. It's a lot of states that have done it, and it's a lot of facilities within those states that have done it, including every neighboring state to Nevada. So in my research, I did not come across a lot of concerns or issues around level 4 designated facilities.
Thank you, I appreciate that. Yeah, I was shocked too. I did not realize that many states that actually had level 4s now. Been out of the system for a while.
Assemblymember Edgeworth.
Thank you, Chair. Thank you for bringing this bill. I think as somebody, I'm a physician and I trained at UMC Hospital, and almost dead people, they were almost dead by the time they got to UMC because it's so far from rural areas. So I wonder how many people could have been saved with this designation. My question is, Nevada has a real paucity of medical providers, and my guess is that becoming trauma 4 would require additional staffing. Are you worried that implementing this that there'd be problems because we literally don't have enough people, practitioners, nurses, all different kinds of people?
Thank you, Assemblymember Edgeworth. Blaine Osborne, Nevada Rural Hospital Partners for the record. No, while we are very worried about the shortage of providers we have in the state and work on that issue every legislative session with you all, no, we are not concerned that that additional staff needs to be brought in either to the state or to the facilities. I think the difference is the training, and that is where we can train up the providers and the nurses in our emergency rooms currently.
Greg Koenig for the record. Definitely not the expert on this, but I have done some reading on it since I have a bill here. I actually think that it will be a potential benefit to recruit practitioners to these rural hospitals because now they know that it's a level 4. Having that designation makes it more desirable to serve in these because now they are going to a level 4 facility.
Thank you for the thoughtful response. I love that answer.
Thank you. Our next question is from Assemblymember Hunt.
Thank you, Chair. Thank you guys for the presentation. You know, my question, I think about, UMC being the only one in Vegas, right? And if you get the care with level 4, then they can charge you the trauma fee, right? Say like you go in for something small, you get charged the trauma fee?
Thank you, Assemblymember Hunt. Blaine Osborne, Nevada Rural Hospital Partners for the record. Yes, you're correct. University Medical Center is the only level 1 facility in Clark.
Level 1, I'm sorry.
There are additional trauma-designated facilities within Clark County. And yes, trauma-designated facilities have the ability to charge the activation fee, and those vary across states and across the various levels of the designation.
Okay, I just want to clarify my question. Yeah, I'm thinking trauma 4. If you go to a trauma 4 designated area with a small injury, are you going to get charged that fee if it's not trauma related?
Madam Chair, Jeff Prater for the record. If it's not trauma related, no, that's nothing.
Thank you. Our next question is from Assemblymember Hafen.
Thank you, Madam Chair. Not a question, but a disclosure. I do serve as the chairman of Desert View Hospital Board, which is a critical access hospital. Just wanted to put that on the record. Thank you.
Thank you for that disclosure. Members, any other questions? One more. Go right ahead.
I just, and this is just clarifying the way I remember it. So if you go to a trauma facility and it's a trauma activation, that patient does get, regardless of the injuries, could be the mechanism of injury, they could still get charged the trauma activation fee. However, if you're a walk-in with a cut finger, it's just going to be your normal level severity based on the treatment, correct? So your average guy walking through the door is not going to get charged the trauma fee. Thank you.
Good. Thank you, Assemblyman Gray. Yes, great question. You are absolutely correct in that. I apologize. This mic is having some issues.
It's doing the blinking.
It's blinking.
Sorry, Mr. Osborne, it's because you forgot to say your name and therefore it does not work.
Blaine Osborne, Nevada Rural Hospital Partners for the record. Thank you.
You're welcome. I have one additional question, seeing no others from our members. Mr. Osborne, you did state in part of your testimony today that the other hospitals, level 1, 2, and 3, would be forced to communicate with level 4 trauma centers. I'm wondering if you would clarify, what does that system look like currently in Nevada, and what would be necessary to bring on level 4 communication?
Yeah. Thank you for the question, Madam Chair. Blaine Osborne, Nevada Rural Hospital Partners for the record. Yes, I think not only are they forced to, they are also strongly incentivized and encouraged to do so. Or in Southern Nevada, the Southern Nevada Health District that has created that system. Currently, as I said in the north, transfer agreements are in place between emergency rooms I'm sorry. The transfer centers, transfer agreements are in place currently between emergency rooms and hospitals, but that is not the case for those trauma designations because we only have one trauma center in the north. Does that answer your question?
Thank you. Yes, it's very helpful. As your microphone is going off and on, mine is as well.
Oh, good.
So somehow they're magically connected today.
That makes me feel better.
Members, are there any other questions? Okay, seeing none from members at this point, I will say thank you for the presentation. If you will please step back at this point. We will now take testimony in support of this measure, Assembly Bill 326. We do have overflow space next door, so if you are next door and you would like to come and offer testimony in support, please come forward. Also in Las Vegas, I see we have someone there. If you are here in support, please come forward. You may begin when you're ready.
Good afternoon, members of the Assembly. My name is John Elliott, and I'm an ER physician and current trauma director at Carson Valley Health. I'm here today to express...
I'm sorry, Mr. As you can see, we're having a bit of technical difficulty. We're going to take a brief recess. If you will just stay put for one. We're going to troubleshoot some technology. We're in a brief recess. We're having technology.
a pair in my bag if you want. They're all black. Do you still make the guy do this? Yeah. It's also called the presbyopia thing. Where did them? I got mine at Costco. Well, like, you are so restrictive of your hands that they were inefficient. How much you shifted focal point in the classes. Yeah. It's like a lot of what I think that scopes from 5, 7, 9. I just do one classes. I was just like I knew that type to do a little of this, but I truly had recorded really and had broken scopes. Oh my goodness, couch.
Okay, members, we have an update. It looks like it's a system-wide outage that we're experiencing. We're going to reset the system, so we are officially going to stand in recess until 2:30, and then hopefully the system will be up and running at that point. We will then open up for comments and support, opposition, and neutral on this measure. So we are in recess until 2:30. Please don't be late. Thank you.
I'm just waiting for one.
Thank you for your patience. We will officially call this meeting back to order, and we will go back to our last order of business, which is following up on the bill hearing for Assembly Bill 326. We are now hearing testimony in support of Assembly Bill 326. If you would please state and spell your name for the record, and 2 minutes. You may begin when you're ready.
All right. Members of the Assembly, my name is John Elliott, John-E-L-L-I-O-T-T. I'm an ER physician and current trauma director at Carson Valley Health. I'm here today to express my strong support for AB 326. As a rural critical access hospital, Carson Valley Health provides excellent initial and stabilizing care for patients who have experienced traumatic injuries. A trauma designation would enable rural hospitals like CVH to enhance the care that we already provide through several key initiatives. As previously mentioned, formal quality assessment and improvement programs. This would allow us to consistently review and refine our trauma care practices with oversight from the state. We would monitor and improve essential metrics such as nursing triage times, time to physician evaluations, imaging and lab draw times, pharmacological interventions, and patient transfer times. We would improve our transfer efficiency by streamlining the transfer process for injured patients to higher levels of care. By enhancing these protocols, we can reduce the delays that could impact these traumatically injured patients. And then thirdly, community outreach and education programs. Level 4 designated centers aim to implement formal initiatives focused on injury prevention and initial trauma management for community members. For example, programs such as Stop the Bleed have equipped individuals with skills to recognize and respond to life-threatening bleeding by applying pressure, packing wounds, and using tourniquets in the field prior to receiving that initial care. So your support of AB 326 is crucial in helping us elevate the standard of care we provide and improving the outcomes for patients suffering traumatic injuries in rural Nevada. Thank you for your time and consideration.
Good afternoon. I'm Dr. Kathy Glauner. It's K-A-T-H-I-G-L-A-U-N-E-R. I'm an emergency medicine physician and the emergency department medical director at Carson Valley Health, and I'm here also to support AB 326. As an emergency department in a critical access hospital, we frequently see trauma patients who are injured near our facility or at even more remote locations. While we care for these patients professionally and with all resources available to us, passage of this bill would allow us to formalize and improve our care of trauma patients in multiple ways. Today, I'll focus on benefits that patients derive from the improved training and coordination of critical access staff working in hospitals with trauma designations. 1, faster response times. There's no question that well-trained and coordinated staff can respond more quickly to trauma cases, which is a crucial step in saving lives and minimizing complications. Quick recognition of the severity of the trauma can help to prioritize care and streamline important interventions such as stabilizing patients, administering pain medications, and initiating transfer to a higher-level trauma center. Enhanced clinical skills. Continuous training ensures that ED staff are equipped with the latest knowledge and skills to manage traumatic injuries. This net is broad and includes understanding trauma protocols, using diagnostic tools efficiently, and performing life-saving procedures. Clear communication. Coordination of care improves communication among doctors, nurses, technicians, and other personnel. This ensures that critical information is both obtained and shared effectively, minimizing the risk of errors and delays in care. This is especially important in cases of critically injured trauma patients. Better patient outcomes. With highly trained ED staff working in a coordinated fashion for the benefit of patients, the quality of care improves, leading to better patient outcomes, including reduced risk of complications, improved recovery times, and potentially many lives saved in rural and underserved areas. Ultimately, well-trained and coordinated ED staff working under the auspices of a trauma program will provide the best possible care for our trauma patients, ensuring that they receive prompt, skilled, and efficient treatment, even in a limited resource rural environment. Thank you.
Good afternoon. Can you hear me?
Perhaps that is the troubling microphone.
How's that? All right. Good afternoon. Thank you, Madam Chair and committee members for this opportunity to speak today. My name is Dr. Kandra Yee. It's K-A-N-D-R-A-Y-E-E. I'm a board-certified emergency physician at Carson Valley Health and CEO of the physician group that staffs our emergency department there. I sit before you today in strong support of AB 326, which proposes to permit the level 4 trauma designations within our state's critical access hospitals. As emergency physicians in rural Nevada, we face a lot of unique challenges. We are, in essence, de facto trauma designated emergency departments, already seeing and treating severely injured patients regularly. My colleagues and I possess the specialized training and expertise necessary to stabilize trauma patients. We are prepared. However, without the level 4 trauma designation, we are limited in our ability to fully leverage this expertise for the benefit of the wider community. I don't think this bill is about changing what we do, but it is about enhancing how we do it. Establishing level 4 trauma designation would allow us to formalize our processes. Through this, we can develop standardized protocols in close collaboration with local EMS and the regional trauma centers. It will ensure seamless patient handoffs and optimized care. Second, we can implement a robust feedback loop. We can establish formal mechanisms for performance improvement. We can learn from each case and refine our practices. Third, we can improve coordination. The designation will facilitate stronger communication and collaboration with the regional trauma centers, ensuring patients are receiving the right care at the right time and in the right place. The reality is our rural communities deserve the same standard of emergency care as their urban counterparts. This bill is not about creating a new level of care. It's about creating a stronger, more organized and efficient system of care. By permitting level 4 trauma designations, we are strengthening the safety net for our rural patients, ensuring that they receive the critical stabilization they need before being transferred to definitive care. It's about saving lives and improving outcomes. I urge you to support the legislation, and I thank you for your time.
Hello, my name is Amy Hines Sutherland, AMYHYNE-Sutherland. I am the Health and Human Services Manager for the Nevada Association of Counties, NACO. NACO supports all 17 counties, and we're here to support AB 326. Counties would like to see the great work of our critical access hospitals recognized through this designation. We support the additional improvements to care that would be encouraged through this measure. And additionally, and very importantly, this designation will encourage community members to access care locally, trusting in its quality, and ensuring a sustainable healthcare ecosystem in our rural areas. Thank you.
Good afternoon, Madam Chair, Vice Chair, and members of the committee. My name is Sarah Adler with Silver State Government Relations. And first, I personally live in Douglas County. I bike ride a lot, and a bear visits my house. And so I think this is a great idea. But more importantly, I represent the Nevada Advanced Practice Nurses Association, or NAPNA. And advanced practice nurses, registered nurses, are important contributors to healthcare in our state. And to concur with the sponsor, they welcome a high level of responsibility and challenge. And I think being able to serve at a trauma center will actually incentivize and magnetize APRNs to serve in rural Nevada. So NAPNA urges your support for the bill. Thank you.
Association. We are our critical access hospital members who want to enhance emergency medical services in their communities. Thank you.
Good afternoon, Chair, members of the committee. Paul Morak from the Vegas Chamber. The Chamber is in support of AB 326 in the premise of the bill. We believe that this will help, of course, increase access to our rural residents in the community, which also benefits our urban settings as well. Thank you very much.
Thank you, Austin Daly, AUSTINDALY, on behalf of the University of Nevada. We are proud to be in support of AB 326, which would complement technical assistance to all 13 Nevada critical access hospitals provided by the Nevada State Office of Rural Health, based in the University of Nevada Med School over the past 25 years. This technical assistance includes rural trauma, team training, and generally aims to improve viability of critical access hospitals and the communities they serve. This bill would bring us in line with our fellow Western and Mountain West states. We want to thank Assemblymember Koenig for bringing this bill forward. Thank you.
Thank you. Is there anyone else here in Carson City in support of Assembly Bill 326? Seeing no movement. Anyone in Las Vegas in support of Assembly Bill 326? I see no movement. AVH, would you check the telephone lines to see if there's anyone in support of Assembly Bill 326?
If you would like to testify in support of Assembly Bill 326, please press star 9 now to raise your hand in the queue. Again, if you would like to testify in support of Assembly Bill 326, please press star 9 now. Chair, there are no callers wishing to testify in support at this time.
Thank you. At this time, we'll move into opposition. Is there anyone here in opposition of Assembly Bill 326? Please come forward at this time. Carson City. Seeing no movement in Carson City. Is there anyone in Las Vegas in opposition of Assembly Bill 326? Seeing none. AVH, would you check the telephone lines? Is there anyone in opposition for Assembly Bill 326?
If you would like to testify in opposition to Assembly Bill 326, please press star 9 now to take your place in the queue. Chair, there are no callers wishing to testify in opposition at this time.
Thank you. At this time, we'll move into neutral testimony. Is there anyone here to offer comment in neutral on Assembly Bill 326?
If you would like to testify in neutral for Assembly Bill 326, please press star 9 now to take your place in the queue. Caller with the last 3 digits, 051. You are unmuted and may begin.
I think that when we're designating these trauma centers and doing all this, which is great.
Excuse me, would you please state and spell your name?
My name, sorry. Barry Johnston, BERRY JOHNSTON, Las Vegas. So I think it's great that we're doing the trauma centers, but one of the problems that we have in Nevada, specifically in what I've had experience with the level 1 trauma center at UNLV, when you have doctors like Karen Nelson and Janelle Pategra there, you have run into a situation to where they allow their residents to do more work than they're actually doing, right? So the attendings aren't showing up and doing what they're supposed to, and they're not really a level 1 trauma center because you have children working.
Sir,
on you,
excuse
right?
me,
Like
are
the
you in
students-
neutral on this measure? Are you here to offer neutral testimony on Assembly Bill 326?
Yeah,
Okay, thank you.
right. Or did you cut my time?
No, we're having difficulty with our technology, and I just wanted to make
Oh, I'm sorry.
it sounded.
Give the nerds a hug, and maybe they'll get it done faster. Are we still having technical problems, or can I continue?
You can go right ahead.
Okay, thank you, ma'am. So when you have UNLV working in UMC, right, there's a lot of attendings, and we have a giant problem in Nevada with the resident doctors who are allowed to do work that the attendings should be doing, right? So my mom is a senior. She broke both of her hips. Karen Nelson did one. Janelle Protegra did the other. And in that process, the residents were in there way too much without the attendings, right? They were basically doing the job of the attending doctors, which is not supposed to happen. It's illegal. So we're not getting level 1 trauma care maybe at the very beginning when they first walk in, but then those doctors who are the level 1 care providers are pawning the work off to these other savvy doctors like Karen Nelson and Janelle Pategra at UMC. Those doctors should not be working with the elderly. So when we're trying to claim that we're at this level, we have to make sure that we're maintaining that level, because if we don't, there's going to be elderly people that are hurt, like my mother, who couldn't walk because of Karen Nelson and Janelle Pategra's terrible job, and them allowing their students to do more work than they were actually doing. And then they didn't follow up at all on any of the PT or anything like that. So you can't call yourself a Trauma 1 facility just by throwing one guy like, Eric Kubek out there and saying, yeah, he's great. And he could probably do all kinds of wonderful things.
Thank you.
but these
Thank you
other
so much
doctors
for
are
calling.
savvy.
You are over your 2 minutes at this point in time. You're welcome
Thank
to
you, ma'am.
submit additional
Have a good day.
comments in writing. Thank you.
If you have recently joined and would like to testify in neutral to Assembly Bill 326, please press star 9 now to take your place in the queue.
Good afternoon, Madam Chair and members of the committee. For the record, my name is Robin Dunkhorst. I'm the CEO of Humboldt General Hospital and a 20-year emergency room nurse here in Winnemucca. I was unable to join the queue for support, so I hope that neutral is okay. I'm here to advocate in support for Assembly Bill 326. This bill will allow for the development of a level 4 trauma center designation in the state of Nevada at critical access hospitals. As you know, Nevada's vast rural communities are separated by long distances, with some living more than 200 miles away from the nearest full-service tertiary hospital. When minutes matter, access to trauma care can mean the difference between life and death. Critical access hospitals, such as Humboldt General Hospital, already serve as the first and often only point of emergency care for trauma patients in rural Nevada. However, without a level 4 trauma designation capability, our hospitals lack access to critical resources, funding, and the training that could enhance our ability to stabilize, treat, and transfer patients efficiently. We can strengthen our rural health system, reduce preventable deaths, and ensure all Nevadans, regardless of where they live, have access to timely and high-quality trauma care. Did you know that in 2023, Humboldt General Hospital served 70 trauma patients that fell into significant trauma criteria? While 70 may seem low, and certainly is low in comparison to our tertiary partners, these are 70 rural lives that were impacted. Level 4 trauma designation will allow us to develop our trauma system to help ensure that those patients have the highest level of care possible in our area. It will give us the ability to enhance the care that we provide, ensuring that even if the patients require a higher level of trauma care, that we have a developed system in place to effectively resuscitate, stabilize, and transport to our tertiary trauma partners in a way that best maximizes the outcome for our trauma patients. It also would ensure that we're committed to trauma reduction and prevention community education and strategies. I urge you to support the development of the trauma systems within Nevada, and that includes supporting Assembly Bill 326. Thank you.
Chair, there are no other callers wishing to testify at this time.
Thank you, AVH. I appreciate the current situation and flex. I just want to make sure that we give folks an opportunity to come in support, opposition, and neutral. And if we've missed anyone who would like to offer comments on this bill, that you are given an opportunity to approach. Okay, seeing no movement, thank you. We appreciate that. Thank you, bill sponsor. Do you have closing comments?
Thank you, Chair. Appreciate this committee hearing Bill AB 326 today. I really that if we're able to pass this, it'll increase the efficiency and the timeliness and the quality of care received by the people in these hospitals. You know, when I took on this bill to begin with, I was looking for something that would affect, the rurals. But the more I got into it, this is something that won't just affect the citizens in my districts, but it's going to help everybody in the whole state. I mean, every single one of you is driving back and forth between here and there and in the middle of nowhere. And so it's not just going to affect just the people that live in that area, but the people passing through and all the citizens of this whole state. So thank you.
Thank you. We will officially close the bill hearing on Assembly Bill 326. Okay. All right. Need to limp along.
Have to keep tapping. Okay. But use the last chair. That's the mic, the chair to you. Control it. Yeah, that's the best mic. That one.
Thank you. We're gonna continue to work through our agenda and see if we can keep our technology functioning. So we will go ahead and open the bill hearing for Assembly Bill 360, which revises provisions relating to testing for sexually transmitted diseases. Assembly member, you're welcome to take the table. I would simply ask you to watch your microphone buttons, because when your microphone goes out, we are not recording, and we have accessibility issues. If it gets to a point where we cannot proceed, we'll just recess, okay? So you are welcome to begin if your microphone is.
So if you're speaking, can the person next to you?
Thank you, I appreciate that.
We're going to keep hitting
Live.
this mic and vice versa.
Members, I will caution you, your microphones might be going live on a moment's notice, so just be cautious in front of your microphones.
Thank you, Chair. We're going to give this a try, tag teaming on the technology. Good afternoon, Chair Brown-May and members of the HHS committee. I'm Heather Goulding. I represent Assembly District 27, and I am honored to have the opportunity to present Assembly Bill 360 to you today, a crucial piece of legislation aimed at addressing the very alarming rate of congenital syphilis in Nevada. Congenital syphilis occurs when syphilis passes from a mother to her baby during pregnancy or birth. AB 360 builds on AB 192, which was passed during the 2021 legislative session. AB 92 was the product of the Interim Legislative Committee on Health, and it began the important work that this bill continues. AB 360 will increase access to syphilis testing and treatment for pregnant women who have not received prenatal care. In 2017 to 2020, Nevada ranked number 1 in primary and secondary syphilis rates in the United States. We currently rank 9th, not because our numbers have improved, but because other states are catching up with us. And we rank 6th nationally for congenital syphilis infections. Our statewide average rate of 232 cases per 100,000 live births is more than double the national average. Clark County has seen a staggering 1,600% increase in congenital syphilis cases from 2014 to 2023. I am joined today by Dr. Tim McFerrin, an obstetrician gynecologist and representative of the American College for Gynecologists, and by Jennifer Howell, the Sexual Health Program Supervisor at Northern Nevada Public Health. These subject matter experts will give you an understanding of the real-world consequences of these startling statistics. They will address the dangers of syphilis and congenital syphilis and how public health systems, and moreover, Nevadans, can benefit from this bill. After they share their testimony, I will walk through the conceptual amendment that has been posted on Nellis, and you should have copies in front of you. Thank you.
Good afternoon. Good afternoon, Chair Brown May and members of the committee. My name is Jen Howell, Sexual Health Program Supervisor at Northern Nevada Public Health. I'm here today to share.
I wonder if you could move to that microphone. It seems like.
Okay. I'm here today to share experiences in the public health response to the increasing burden of syphilis in Nevada, with an emphasis on the burden of congenital syphilis. You heard the statistics, I won't repeat them for you, but Washoe County is experiencing a significant increase in cases, with Clark County having experienced increases during different time periods since 2005. Rural communities are also facing an increase in cases, with less resources and experience with syphilis than Washoe and Clark counties. The CDC has noted that congenital syphilis cases are a sentinel event that should be examined to identify where prevention, testing, and treatment efforts broke down as factors impacting the transmission from mother to baby, and also how those factors can be addressed to prevent future cases. Among maternal cases of congenital syphilis cases, many characteristic trends have been noted through a case review process through the statewide Congenital Syphilis Review Board. Case information is provided to a transdisciplinary group of the statewide transdisciplinary group that identifies trends and areas for intervention. Factors identified throughout most maternal cases that led to congenital syphilis cases include polysubstance use, with meth and fentanyl being most commonly reported substances, unplanned pregnancies, transactional sex involvement, partners untreated for their infection, which causes reinfection, fear of social services involvement, missed opportunities of intervention in emergency departments where people are presenting for care, and lack of resources or health literacy needed to participate in prenatal care. For example, from 2017 to 2022, 57.4% of maternal cases in Clark County had visits to an emergency department. To further the movement toward addressing these factors, Northern Nevada Public Health has initiated a Washoe County Syphilis Task Force with community stakeholder involvement. Public health's mission is to promote and protect the health of all communities. Important to note, public health becomes involved when a positive test result is reported, not in the beginning of the process. All positive results with a point-of-care test or rapid and serological tests need to be reported to the local health authority. This allows public health to do their job of identifying infections and then intervening by facilitating treatment and case investigations to contact partners for testing and treatment as well. The timeline for treatment can span up to 28 days for a case and 10 days of IV antibiotics for the child. To further test for signs and symptoms of congenital syphilis, the baby needs a lumbar puncture, x-rays, and blood work. If a case does not complete their treatment within a specific time frame, they must restart the treatment regimen. Treatment in pregnant cases is very specific and cannot utilize alternative treatment. In addition, babies born with syphilis are followed up for follow-up testing and possible intervention for 15 months following delivery. This public health case management does not include follow-up on developmental testing and intervention that may be necessary for the parents or guardians to engage with and address the health concerns of the child. Often, babies born with congenital syphilis become engaged with the foster care system. Other intervention includes follow-up to conduct an extensive interview with the maternal case and to consistently offer services to the case's sexual partners. In addition to major health impacts, congenital syphilis hospitalizations cost an average of $58,000 in the United States, which does not take into account the costs related to public health intervention and ongoing care for the child. Congenital syphilis and syphilis have a tremendous impact on the health of Nevadans. It's crucial to advance interventions that allow timely treatment to prevent cases transmitted to babies and to reduce the burden of this preventable disease overall. Thank you.
Good afternoon, Madam Chairman and members of the committee. My name is Dr. Tim McFerrin, MCFARREN. I'm a board-certified OBGYN and have about 40 years of involvement in public health, as you can see by my gray hair and lack thereof. Syphilis, and especially congenital syphilis, is a preventable disease. The rate of syphilis in Nevada, and especially congenital syphilis, is too high and is really unacceptable, and this bill aims to address this. How do you prevent syphilis? Well, the best way is screening. And syphilis is a bacteria that is sexually transmitted. For most women, there are mild to no symptoms, and most women find out they have syphilis by screening, not by examination. Congenital syphilis, as Ms. Howell said, happens when the syphilis bacteria happens to pass to the fetus from the mother. It infects the placenta. It passes easily to the fetus. It affects the brain, the heart, the liver, bone marrow, and bones. In untreated mothers, 40%, there's a 40% chance the baby will be a stillborn or die. Those that survive can have blindness, cognitive impairment, or worse neurological symptoms, liver disease, heart disease, severe anemia, and easily fractured bones. This devastating disease can be prevented by enhanced screening and treatment. This is where rapid testing comes in. This rapid test is similar to a COVID test, except for it uses a drop of blood like a finger stick for glucose. Reagents are added, and in 15 minutes you have a result. It costs $10. It is 97% sensitive and 98% specific. It allows for initiation of immediate treatment. So why is rapid testing so important to be performed in the emergency departments and hospitals? It's because we want to reach the most vulnerable population, those pregnant patients that aren't getting prenatal care. And as Jen said, over 60% of mothers who deliver a baby with congenital syphilis who have no prenatal care have made at least one visit to the emergency department. So by not accessing, just kind of a statistic of, and this was in Nevada, of 195 mothers who gave birth to a baby with congenital syphilis, 112, or about 60%, as Ms. Howell said, were seen in the emergency department. But of those seen, only 70% did not receive testing. And this points to a lack of testing in the emergency departments and missed opportunities to prevent congenital syphilis cases. And then why is treatment so important to be initiated in the emergency department? As Ms. Howell and the Southern Nevada Health District would say, it is extremely hard to track down and find these patients for various reasons. They may be homeless, live in a car, to try to track them down and initiate treatment. So that's why we're asking for initiation of treatment in the emergency room. And it's been my experience over 40 years that when you inform a mother that she has a disease that is can be treated so that her fetus is not harmed, they get the follow-up care they need. They care about their baby. There is flexibility in this bill that allows for emergency departments and hospitals to use their traditional blood screening or a rapid test. There's also a confirmatory test that Ms. Howell described. So in summary, syphilis in pregnancy and the resultant congenital syphilis is a preventable disease. The emotional, physical, and financial cost to the mother, family, and society cannot be measured. So I urge you to support AB 360.
Musical chairs again.
Yeah.
Heather Golding for the record. I just want to walk you through, I think you can see the magnitude of the problem here and what the issue is. I want to, for a bit of context, AB 192 that was passed in 21 focused on meeting pregnant women at highest risk for syphilis where they are most likely to interact with the healthcare system. This is in emergency rooms, as you just heard of those moms that are passing syphilis on, where this is the chance to provide treatment. The 2021 law required that hospital emergency departments test pregnant women for syphilis if they had not already received prenatal care. However, it's been reported that that testing isn't routinely taking place. The modifications made in AB 360 seek to clarify the testing and treatment requirements to increase compliance. AB 360 adds the requirement in Section 1, Paragraph 1, Subsection C, that the test is a rapid test, as we've just heard the importance of a rapid test. And it needs to be performed regardless of the reason that the mother is visiting the emergency room. These requirements respond to the realization that this intervention is the most successful if the patient doesn't have to return to the hospital to receive the test results and begin treatment. It requires that the emergency room intervene and begin treatment in that single visit. The amendment language adds "or point of care." You can see that in the amendment that you've received after the word rapid. This is to provide some flexibility. We worked extensively with our stakeholders and recognized that there were some opportunities to provide flexibility within the context of making sure that the testing and treatment were encapsulated in that one visit. The amendment language also addresses the appropriate form of testing dependent upon whether the pregnant woman has a history of syphilis or has been tested within the last 3 months. The protocol indicates that if the test result is positive, treatment will be initiated during that visit. This is the goal of the bill, to increase syphilis testing in pregnant women in order to protect babies from congenital syphilis. The amendment also requires that if a woman refuses testing, the care provider needs to document that. And there was, we've worked with the stakeholders to make sure that this isn't a burdensome requirement. It's simply a requirement to note that in the the electronic records. The amendment language in paragraph 8 assures that Medicaid will compensate the provider for the rapid or point of care syphilis test. And importantly, paragraph 9 in the amendment requires medical facilities to develop a policy that ensures syphilis testing and treatment, as outlined in statute and in alignment with best practices, is implemented. This policy underscores that testing should be offered regardless of the reason the pregnant woman presents in the emergency room. By ensuring that pregnant women are screened and treated, AB 360 aims to reduce congenital syphilis rates, to prevent infant deaths, and to curb the spread of syphilis in Nevada. It will reduce healthcare costs and reduce health disparities that disproportionately affect marginalized communities. On behalf of the lives that will be positively impacted by this bill, I respectfully request your support for the passage of AB 360, and we look forward to answering any questions that you may have.
Thank you. We do have a few questions. We're going to start with Assemblymember Gonzalez.
Thank you so much, Chair, and thank you so much for the presentation. I do have 2 questions. May I ask the 2, Chair? Thank you so much. So in my first question, when you stated that Medicaid will reimburse for these tests, is that only Medicaid reimburse, or is that only Medicaid providers, or is that any provider can ask for a reimbursement through Medicaid?
I'm not sure exactly the question, but any provider who's taking care of that patient would be able to be reimbursed for their care. If it's an ED doctor or OBGYN or family practice, or, I mean.
Heather Goulding for the record. So what we know that the population that is at highest risk, and that it's a very specific population that we're talking about, and they're either most likely already on Medicaid or Medicaid eligible once they're pregnant. So we focused on making sure that Medicaid would cover the test and the treatment. The pushback that we were hearing from hospitals was that it wasn't covered under the previous, under AB 192. So we've been working with Stacy Weeks, and she recommended this additional language to make sure that it would be covered by Medicaid.
Thank you so much. So just clarifying, this is only for hospitals, providers that work in the hospital?
It's not just hospital emergency rooms, but that's where we're focusing the language. There are other hospital facilities that are included. You may note that urgent cares aren't included because there's some complications in statute about urgent care. That may be an opportunity for future cleanup language, but right now, emergency rooms and similar type facilities. Any clarification needed on? No, okay.
I think labor and delivery units would be considered part of the hospital.
I'm gonna interrupt if you don't mind. Remember to state and spell your name. State your name
Tim
for the
McFerrin,
record.
MD.
Thank you.
Thank you so much. And my last question, that helps me with my next question, because I was curious, in the amendment in Section 8, it says physician assistant, or advanced practice registered nurse. So I was wondering, when I think about prenatal care, right, I also think about registered midwives. So I was wondering, were they purposely left out? Do they work in the hospitals as well? Just curious about if they come into contact with a vulnerable patient, would they be able to do this and then be reimbursed for that as well?
Thank you for the question. Heather Goulding for the record. If a pregnant person is receiving prenatal care, this is a standard practice. The difference in this bill is that we're talking about patients that arrive in an emergency room who are not arriving for prenatal care. They're there because they need stitches or they have a sprained ankle. And we know that since 70% of the folks that are passing syphilis on to their babes are making an emergency room visit, that we're not talking about standard prenatal care. It would already be covered. So I think that you're talking about a standard prenatal care. This is kind of outside standard prenatal care.
Thank you for my question was just if they work in hospitals, midwives, and if they would just be part of because it's very specific about who is attending to a pregnant person. So I was just curious, would they be included in that? Are we excluding any other providers that would come into contact with these folks? I guess if that clarifies.
I think they would already be included.
Thank you. I'm going to remind you to state your name for the record every time.
This is Heather Goulding. I think they would already be included.
Thank you. Our next question is from Assemblymember Edgeworth.
Thank you so much. Thank you, Chair. Thank you for this really important topic. The medical community is very familiar with how terrible this has really affected lots of different medical professions, including dermatology and everything else. But I appreciate you shining a light on this. Really important that we fix it. My question is, I realize that Medicaid does cover all prenatal testing and RPR and the testing that's involved in syphilis. So I realize what you're trying to do is get more testing implemented. My question is, and hopefully you know, there are populations of people who are uninsured and do not have Medicaid and are pregnant, specifically large populations of perhaps undocumented people who are uninsured for that reason, for example. And because they're getting this testing done in the emergency room, would it then be covered by EMTALA, like emergency Medicaid? If you don't know, it's okay. I can probably check it.
Heather Goulding for the record. Let me follow up with you. I think that there's a fund for uninsured that may cover this. We're working with the hospitals very closely. Bottom line is that the cost incurred on these tests is so much smaller than the cost of an infant with congenital syphilis that that overriding balancing out of the cost of the test and the treatment is so much less that it's beneficial to go ahead. I will get back to you with the specifics of where that is coming from. I know that there are a number of hospitals in the room, representatives from a number of the hospitals in the room, and they may be able to address that as well when they testify.
Thank you. Chair, can I have one more tiny question? My other tiny question, again, not to put you on the spot, and it does make perfect financial sense. You don't have to argue with me on that. My question is, are there other states that have laws just like this, kind of where it's been implemented like this?
Heather Goulding for the record. We're checking, and that was one of our research questions at LCB to see if anybody had specifically pointed to this rapid testing in an emergency room environment. We've not seen it yet. Not to say that it's not there. It's a little bit tricky to find that very specific of a.
Tim McFerrin for the record. HHS and CMS is one of their recommendations to do rapid testing for this, but it's not a requirement. It's a recommendation.
Thank you for your answer. Thank you. Thank you for what you're doing.
Thank you. Next question we have from Assemblymember Nadeem.
Thank you, Madam Chair. Thank you for the presentation. So my question is, once a patient comes with the syphilis problem in the hospital and the treatment starts, so is it that how the treatment will go? Is it going to be all the treatment is going to be in the hospital, or later on the patient will be referred to the clinic?
Thank you for the question. Jennifer Howell for the record. So treatment can be initiated in the hospital. To determine how much treatment needs to occur, then that's part of our public health investigation. And so if the treatment can't be completed in the hospital and there needs to be further treatment, then it's up to public health to track the person down and provide that treatment, whether it be out in the field, in our clinic, or wherever that may be.
Thank you.
Members, any other questions? Go ahead, Assemblymember Gonzalez.
Thank you. Thank you so much. I have so many questions today. So based off of that last question, how effective is a one-time treatment if you are not able to reconnect with that patient?
Jennifer Howell for the record. I'm not sure exactly, but one treatment's better than nothing. And it could be that that person only needs the one treatment based on what stage of disease that they're in. And so it may be that that will do it, or it may be that they need continuous treatment, but at least there's something that's been done, initiated. Thank you.
Thank you. Okay, seeing no other questions, we'll ask you to go ahead and step back from the table. We will now open up testimony in support of Assembly Bill 360. If you are here in support, I believe the microphones may very well be working, so you are welcome to try to fill in all three chairs and we can see if it works. If not, we're just going to play musical chairs, and I would like to thank you for your cooperation. State and spell your name for the record. You have 2 minutes, and you may begin when you're ready.
Thank you, Chair and Committee. My name is Dr. Chris, K-R-I-S, Dieter, D-E-E-T-E-R, M.D., M.B.A. I am the Chair of Pediatrics at UNR Medical School and the Physician-in-Chief at Renown Children's Hospital. I'm a board-certified general pediatrician and a pediatric critical care physician. I'm here today to present the child's perspective as they can't speak for themselves. I've been in practice for 25 years and have personally witnessed the positive impact of prenatal testing and treatment of diseases like syphilis. I've also seen the painful consequences for the baby when the mother does not receive care. You've heard about the possible consequences, including stillbirth and prematurity. I just want to clarify for the last question, for the mother, it depends on if it's primary, secondary, or tertiary syphilis. They may receive one dose of iambicillin, or they may receive multiple doses separated by a week. Depends on the severity. For the baby, it's very different. When a pregnant woman has syphilis, the infection can spread in utero before the child's born. Delayed diagnosis and and treatment can lead to late persistent clinical features, including intellectual disability, skin rashes, hearing and visual deficits, severe anemia, meningitis, liver failure, splenomegaly, and skeletal abnormalities. We're wearing green today for Behavioral Health Day for Children's Week. Thanks for having us. Our advocacy includes children with congenital syphilis by default. We assume they will have intellectual disabilities, and they are included in our Nevada early intervention system because we worry about autism, developmental delay, and learning disabilities from the start. It is the only default population placed into that program. While awaiting lab confirmation of abnormal findings, the baby has to go through extensive workup. And this is when I talk about the pain for the baby. They're taken from their mothers right after birth, held down in our neonatal unit, and we try to collect blood. If you can imagine a chubby little arm and a little blood vessel smaller than a spaghetti. We're trying to get blood out of that baby's arm, and then we have to do a spinal tap, hold them in a fetal curled up position, and poke their lower backs. They're admitted to the neonatal unit then for multiple x-rays, for brain imaging, an eye exam, and a hearing evaluation. In order to protect them from further disability, we have to quickly start treatment. While treatment for the pregnant mother could have been those 3 shots of penicillin, for the baby, we have to place a deep IV line so it's permanent, doesn't fall out during their days of treatment. Very difficult to place. We have to expose them to x-rays to confirm the placement of that line, and then we give them 10 days of IV penicillin to treat their syphilis. As their doctor, my heart breaks for my littles, knowing that this was all preventable. As this is only their first week of life, after diagnosis and treatment of syphilis, close monitoring is then required with repeat blood draws every 2 to 3 months, repeat imaging, spinal taps, eye exams, etc. All of this could have been avoided with improved screening and prenatal care for young mothers. Thank you for your attention to this matter and for prioritizing children this week.
Good afternoon, Chair Brown-May and members of the Assembly Health and Human Services Committee. My name is Jamel Nance, and I'm the Early Childhood Policy Director with the Children's Advocacy Alliance. CAA is an independent voice for Nevada's children advancing systemic change in the areas of early childhood, children's health, and child welfare to ensure every child in Nevada thrives. I'm here today to speak in strong support of AB 360, a bill that strengthens health protections for pregnant people and their babies by ensuring timely, accessible syphilis testing. This legislation is critical because untreated, syphilis during pregnancy can lead to stillbirth, as you've heard the doctor share, birth defects, and lifelong health complications for newborns. We know that children who are exposed to syphilis during birth have high rates of medical and developmental delays. These delays can include intellectual disability, visual, hearing impairments, and other disorders that impact learning. For many of these children, the state will be covering these extensive services through Medicaid. Fortunately, AB 360 mandates rapid point-of-care testing, ensuring that expectant mothers, especially those who have not received prenatal screenings, get tested and treated immediately. By requiring Medicaid and private insurers to cover these rapid tests, AB 360 removes financial barriers, making screenings more accessible to low-income families and communities of color who face higher rates of congenital syphilis. This bill is a public health win, and it promotes early intervention, preventing unnecessary infant deaths and reduces long-term health care costs, ensuring that every baby has a healthy start in life and is a shared responsibility. Please consider supporting AB 360, preventing congenital syphilis. It is not just possible, it is necessary. Thank you for the opportunity to provide testimony.
Thank you, Chair and members of the committee. Bradley Mayer today testifying in support on behalf of Southern Nevada Health District, and we thank Assemblymember Golding for engaging us on this bill. You heard about some of the complications that can lead to from congenital syphilis cases, and from 2009 to 2023, Clark County reported an average 5-year rate of 172 congenital syphilis cases per 100,000 live births. And these cases disproportionately affect babies born to Black, non-Hispanic women, women aged 25 to 29. Under existing law, you heard about how the testing is mandated during the first and third trimester, but despite these requirements, the majority of women who give birth to infants with congenital syphilis do not report prenatal care. And so a study from us, Southern Nevada Health District 2017 to 2022, revealed that amongst the 195 women who delivered an infant with congenital syphilis, 56% reported no prenatal care, and 57% had at least one emergency department visit during this pregnancy. So I think this data supports the need for rapid testing interventions in emergency care or other medical facility settings, as early identification and treatment of syphilis is crucial to preventing it. To prevent congenital syphilis, pregnant women must be tested and initiate treatment within 30 days before delivery. And once those infections are reported, per NRS 441A, local health authorities like SNHD investigate infection reports, and disease investigation and intervention specialists ensure follow-up testing and treatment for pregnant women and their partners. Efforts like AB 360 increase access to syphilis testing at locations where pregnant women who may not be connected to regular prenatal care are already seeking medical attention for other health needs during their pregnancy. And for those reasons, SNHD supports this bill. Thanks for your time.
Good afternoon, Chair and members of this committee. My name is Annie Vong, A-N-N-I-E-V as in Victor, O-N-G, with Cartwright and B Government Affairs, and we're testifying on behalf of Nevada Public Health Association and Nevada Primary Care Association. Federally qualified health centers are providers of syphilis testing, including rapid screening, and this bill is a step forward in the right direction. Thank you so much.
Thank you. Excuse me. I'm Dr. Terrence McAllister, T-E-R-E-N-C-E-M-C-A-L-L-I-S-T-E-R. I'm the president of the Nevada chapter of the American Academy of Pediatrics and a practicing pediatrician in Las Vegas. I'm not going to restate everything that's already been said about the need for this testing and about the risk of congenital syphilis to newborns. I'm just going to say something that's very fundamental to pediatrics is prevention. We would much rather prevent a disease than treat a disease. And so that's one thing that this bill will help us to do is ideally to prevent the disease before it even happens to our patients. And so we're strongly in support of this bill. Thank you for your time.
Thank you, Chair and members of the committee. Blaine Osborne, Nevada Rural Hospital Partners. For the record, we oppose syphilis. That's why we support AB 360. And I just want to say to Assemblymember Edgeworth, yes, there probably will be some costs that the hospitals will likely absorb in those cases of patients being uninsured or underinsured. And in those circumstances, we think that the benefits will outweigh the costs. Thank you.
Kent Irvin, Nevada Faculty Alliance. We're always just cautious about new benefits that might affect public employee benefits, but golly, this is a no-brainer, and we just want the best care for our members, their dependents, and especially our students.
Patrick Kelly from the Nevada Hospital Association. We support this bill, and we're very appreciative that the sponsor spent so much time working with us on it. Thank you.
Thank you. Is there anyone else here in Carson City in support of Assembly Bill 360? Seeing no movement here in Carson City, is there anyone in Las Vegas in support of Assembly Bill 360? I see no movement in Las Vegas. AVH, will you go to the telephone lines? Is there anyone here on the telephone lines in support of Assembly Bill 360?
If you would like to testify in support of Assembly Bill 360, please press star 9 now to take your place in the queue. Caller with the last 3 digits, 951, please press star 6 to unmute your phone. You may begin.
Good afternoon, Chair Brown-May, Vice Chair Nguyen, and members of the Assembly Health and Human Services Committee. My name is Sarah Watkins, and I represent the Nevada State Medical Association, the oldest and largest organization representing physicians in our state. NSMA supports comprehensive preventative care for all patients. The performance of a rapid test for syphilis at the point of contact for pregnant patients is important for early detection and treatment. If untreated, syphilis can cause serious health issues for both the mother and the baby, and early testing allows for, if necessary, straightforward antibiotic treatment that can stave off dire consequences. We'd like to thank Assemblymember Golding and other stakeholders for bringing forth this bill, and we were in full support of AB 360. Thank you.
If you have recently joined and would like to testify in support of Assembly Bill 360, please press star 9 now to take your place in the queue. Chair, there are no other callers wishing to testify in support at this time.
Thank you, AVH. At this time, we'll move into opposition. Is there anyone here in Carson City in opposition of Assembly Bill 360? Please come forward. No movement here in Carson City. Is there anyone in Las Vegas in opposition to Assembly Bill 360? No movement in Las Vegas. AVH, is there anyone on the telephone lines in opposition of Assembly Bill 360?
If you would like to testify in opposition to Assembly Bill 360, please press star 9 now to take your place in the queue. Chair, there are no callers wishing to testify in opposition at this time.
Thank you, AVH. At this time, we'll move into neutral testimony. Is there anyone here wishing to offer testimony in a neutral on Assembly Bill 360? Please come forward in Carson City. You may begin. State and spell your name for the record. 2 minutes.
Good afternoon, Chair. My name is Nicole Flangas, Flangas. And for the record, I'm here on behalf of the Nevada Association of Health Plans, a statewide trade association representing 10 member companies that provide commercial health insurance and government programs to Nevadans. We appreciate the intent behind this legislation, but just note that mandates come with unintended consequences that can drive up costs for consumers and reduce plan flexibility. These increased costs ultimately translate into higher premiums and deductibles, out-of-pocket expenses for employers, and mandates can additionally limit consumer choice by requiring all policyholders to pay for coverage they may not want or need, reducing flexibility. As an association, we do remain committed to enhancing healthcare quality and accessibility and welcome the opportunity to collaborate on policy solutions that align with this goal, ensuring Nevadans have both affordable, sustainable, and wide-reaching healthcare coverage.
Thank you, Madam Chair, members of the committee. Adam Plain, Plain, with the Nevada Division of Insurance. We submitted written testimony in neutral on this particular bill. Division of Insurance has not had the pleasure of appearing before this particular committee at this session, so just want to use my time briefly to say that as a regulatory agency, we tend to be neutral on these policy bills. We view it as our duty to inform the committee as best as possible of what may or may not occur and let you as the legislative body deliberate and decide what you want to do on each individual matter of policy. We did submit some supporting documentation, I believe, relating to the topic of federal health mandate defrayal. I submitted it in both narrative and PowerPoint format. So if you're not familiar with what that topic is, you can avail yourself of those items to educate yourself on what federal defrayal is. I'll wrap up by saying that this particular bill does not affect the insurance code, Title 57, directly. But as the Bill Digest notes, there are 4 sections of Title 57 that incorporate this syphilis testing mandate by reference. So the division has taken it upon themselves to evaluate the changes in the bill as it relates to federal defrayal. After review, we've determined that it appears that Assembly Bill 360 in its current form does not trigger federal defrayal provisions. We want to make sure that we establish a clear legislative record of that throughout this session. And then finally, I'd wrap up by apologizing to the bill sponsor. I believe we didn't prepare her for our testimony, and when she read it online, it may have caused some unintended heartache, but I believe that has been resolved. And if there's any questions from the committee, the division is always happy to answer them. And thank you for your time.
Thank you for being here today. I think, do we want to defer to legal? If you have something to add at this point, I would appreciate that.
Thank you, Chair. David Noss, LCB Legal, for the record. As was just stated, yes, there are sections of the NRS that currently require coverage of syphilis testing as it is required by NRS 442.010, the section that is being amended. Those sections are for local governments and PEB, Public Employees Benefits Program, 287.010 and 287.04335. For private insurance, it's quite a few sections, so I'll just give a few and then note that those sections are repeated for each type of insurance. If you'd like the full list, I can give you them. But just a few to save everyone some time. 689A.0412, 689B.0315, and then the Medicaid requirement is 422.27173. Thank you, Chair.
Thank you. I appreciate the clarification. And for the record, thank you. Is there anyone else here in Carson City wishing to offer neutral testimony on Assembly Bill 360? Seeing no movement here, no one in Las Vegas moving forward to offer neutral testimony on Assembly Bill 360. AVH, is there anyone on the telephone lines wishing to offer neutral testimony on this measure?
If you would like to testify in neutral for Assembly Bill 360, please press star 9 now to take your place in the queue. You may begin.
Thank you, Chair and members of the committee. My name is Dr. Michael Powell. That's Michael. I'm the medical director of the laboratory at St. Mary's Regional Medical Center in Reno, and I also teach at UNR School of Medicine. In reading the text of this bill yesterday, I was concerned that the language as written would mandate rapid point-of-contact testing for syphilis in place of the standard serologic testing that is already widely available at hospitals, including our own. At St. Mary's, we have an automated serologic testing using the TPPA test, which is the gold standard test that the 97% sensitivity statistic that was cited earlier is compared to. This test is technically better than the point-of-care tests, and we can perform it in our laboratory in 17 minutes. We were hoping to get clarification if this testing would continue to be acceptable, because we want to be in compliance with this bill should it become law. We strongly support increasing testing for syphilis regardless, but we would like to avoid having to bring in new testing, which is technically inferior to the testing we already offer. Thank you very much for your attention.
Chair, there are no other callers wishing to testify in neutral at this time.
Thank you, AVH. At this time, we'll call the bill sponsor forward for any closing comments.
Thank you, Chair. This is Heather Goulding for the record. The bill does include that the test that was referenced in the call. Thank you so much for the opportunity to present this bill today. This bill represents a dedicated effort from a very broad array of stakeholders to improve healthcare policy for a very specific and devastating healthcare crisis in Nevada. Put simply, AB 360 aims to save lives and reduce suffering. The fact that it also can save an awful lot of money by preventing congenital syphilis is just an added benefit. Thank you so much for your consideration.
Thank you. We'll go ahead and close the bill hearing on Assembly Bill 360. Thank you. We'll move into our next order of business, and we will open the bill hearing for Assembly Bill 349. We will welcome our member to the table. Please take your time and get situated. You may begin when you are ready.
Thank you, Chair. Good afternoon. I'm Assembly Member David Orentlicker, representing District 20 on the southeast side of Las Vegas. Thank you for the opportunity to present Assembly Bill 349, which will address a major cause of the high cost of health care in Nevada, and that's hospital bills. AB 349 will ensure fair hospital charges for state workers and retirees who receive their health insurance through the Public Employees Benefits Program, also known as PEB. Joining me today on Zoom is Dr. Rosalind Murray from the Brown University School of Public Health, and Celestina Glover is the Executive Officer at the Public Employees Benefits Program, is available here to answer questions. So, as I said, this applies to hospitals, surgical centers, and emergency care centers, but not critical access hospitals. That's in Section 4. Why are we doing this? Healthcare costs, as we've heard, are just too high in this country. Here's the United States. We spend over $12,500 per person. Switzerland's next, and less than 2/3 of what we spend. Germany's around that range. And then you look, Canada's half of what we spend. New Zealand, Japan, countries where you get very good medical care, spend less than half of what we do per person. And hospital prices are the largest component of U.S. healthcare costs. Here's a pie chart. Oops. And you see that hospitals are about 31% of healthcare costs. Physicians and clinics are next at 20%. Prescription drugs at 9%. So we want to go where we'll get the biggest bang for our buck in containing healthcare costs, and that's hospital costs. Well, I showed you all these other countries do a better job than we do keeping healthcare costs and especially hospital costs down. What's their secret sauce? That's because their governments limit how much hospitals can charge in all of those countries. Unfortunately, the free market doesn't work when it comes to hospital charges. I majored in economics in college. My wife thinks I believe too much in the free market, but it just doesn't work in healthcare, and especially with hospital charges. Hospitals have substantial market power, and they use it to keep prices higher than would exist in a truly competitive healthcare market. You can think of this as kind of like an antitrust measure, trying to address the problem of market power and consolidation in hospital market. Hospital fees in Nevada, what they look like. So fortunately, there's a lot of good data out there. I encourage you to consult these websites that I referenced. Sage Transparency is one. Nevada hospitals charge, when we're talking about private health plans, 280% of Medicare rates. The national average is 269%. So we're above average in a bad way. Arizona's worse, 307%, Colorado 314%, Utah 228%. So you can see there's quite some variation across states. There's also good data because the hospitals have to report their costs to Medicare every year. How much do they need to earn? And so there are measures from this National Academy of State Health Policy on what's their break-even point. How much do they have to charge commercial plans, the private health plans, to break even? The average in Nevada is 138% of Medicare, which is well below the cap in AB 349 of 175%. Our break-even point is lower than the national average. So we charge more even though our break-even point is lower. Median, that's the average, that's the mean. The medians are even lower, 113% break-even in Nevada. Here's some profit margins. I picked some of the major Nevada hospitals. I won't give you their names, but you would be familiar with them. As you can see, they start at 10% and go as high as 25.5%. There are only two hospitals, the major acute general hospitals in Nevada, that are below 10%. 3 are above 20%. 7 are above 15% profit margin, which is pretty healthy. Okay, what are we doing in AB 349? Section 5 is the heart. We draw on similar legislation that's been in effect in Oregon for several years, and Dr. Murray will talk about what's happened in Oregon. This bill would cap hospital charges at 175% of Medicare rates. That's for in-network. If the plan has a contract with the hospital, we set it lower for out-of-network because we want to discourage hospitals from not contracting and saying, well, I won't contract, I don't like 175%, but they'll get less out-of-network. And that's worked in Oregon. It applies automatically to the state employee health plan, PEB, state employees, retirees. There's an opt-in for local government employee plans. That's a combination of sections 5 and 9. If teachers, police, firefighters, Clark County, Washoe County employees, et cetera. With Medicaid cuts possible, significant ones, there's a provision in section 5 to say if they cause significant financial hardship, DHHS, Health and Human Services, with interim finance approval, can increase the caps if there would be significant financial hardship for the hospitals. So I don't want them to be penalized by if this goes into effect. On the other hand, if we don't have the Medicaid cuts, we should have these caps. What's the impact? So I've shown you 3 different caps. If we do, the bill says 175%, that's bolded. Annual savings for PEB is $36 million, which is we can use right now. If we capped it at 200% of Medicare, it would be 29 million savings. If we went to 150% of Medicare, we'd be at 45 million. Oregon's at 200%. Colorado's bill this session's they're pegging it at 160% of Medicare. So we're in between Oregon and Colorado. But you can see hospital profits barely affected. Their profit on private plans goes down less than 1% with these caps because PEB only covers a few percent of Nevadans who are insured. So not a bit, small impact on the hospitals, big impact on our savings. Finally, Section 6 requires DHHS to study the impact of the caps and report to the legislature every 2 years. And Section 12 provides for another things related, but going in somewhat different direction. Congress passed federal hospital transparency legislation. Hospitals have to post their charges, and this just allows state enforcement to complement federal enforcement. So that concludes what I have, and I'll turn now to Dr. Murray. Thank you for your patience. And as I said, Dr. Rosalind Murray's at the Brown University School of Public Health. They have what I call the dream team of health policy analysis, and they have done really important research in this area. So we're lucky to have her join us. Thank you.
Great. Thank you so much, Madam Chair and Vice Chair, members of the committee. For the record, my name is Rosalind Murray, Roslynmurray, and I'm an assistant professor at Brown University in the School of Public Health. My research focuses on evaluating policies and programs designed to improve healthcare affordability in the U.S., such as those contemplated by AB 349. The information that I'll share today draws on various studies that my colleagues and I have conducted evaluating hospital payment policies and my expertise in hospital payment reform. So as Assembly Member Orlicker noted, hospital prices have been identified as the primary driver of rising healthcare spending in the United States. And this burden of increasing healthcare expenditures is heavily felt by individuals and families through higher premiums, increased out-of-pocket spending, and stagnant wages, as well as job losses, especially for low-wage workers. These premium increases also create significant fiscal pressure on state and municipal health plans, which in turn impacts state budgets. As a result, states are faced with tough choices such as reducing benefits, cutting funding for essential programs, or raising taxes. Now, rather than resorting to these measures, Oregon took a proactive approach in 2017 by passing legislation to cap hospital prices for care provided to state employees. The policy, which was implemented in late 2019, prohibits the state's insurers from paying in-network hospitals more than 200% of Medicare rates for services that are provided to the state employees and their dependents, and services received at out-of-network hospitals. For services that are received at out-of-network hospitals, the cap is set at 185% of Medicare. The legislation affects 24 of the state's largest hospitals, and critical access hospitals and other small and rural hospitals are exempt from Oregon's policy. So the law requires that in aggregate, insurers cannot pay hospitals more than twice what Medicare pays for care provided to Oregon state employee members. So in practice, what this means is that if the state employee plan previously paid a hospital more than 200% of Medicare rates, that hospital must reduce their prices to 200% of Medicare or lower in order to comply with the legislation. So the 200% cap is designed to target the highest outlier prices that are significantly above Medicare rates, which the Medicare Payment Advisory Commission has identified as sufficient to cover underlying costs for efficient hospitals. Also, the 200% cap serves as a price benchmark, not as a price endpoint, allowing room for continued negotiation to occur underneath the payment limits that are established. Now, earlier this year, my colleagues and I evaluated Oregon's policy, and we found some promising results. First, we found that the policy led to a 3% reduction in inpatient facility prices paid per admission by the state employee plan in Oregon, a 25% reduction in outpatient facility prices paid per procedure by the state employee plan, and a 9.5% reduction in outpatient out-of-pocket spending. So essentially, the state employee members paid less in deductibles, co-payments, and co-insurance each time they received an outpatient service after this policy was implemented. We also found that there was a slight increase in service use in the outpatient setting, which suggests that the state employee members are not facing access challenges, at least in the short term. And importantly, we found no evidence of cost shifting to commercial insurance in the first couple of years. So when we examined prices for the broader commercial market in Oregon at these hospitals, we found no evidence that their prices increased over this time period. Now, finally, none of the hospitals left the state employee plan's network, as the lower out-of-network cap encouraged the hospitals to stay in network and at the negotiating table. Based on these results, we estimated that the state employee plan saved over $100 million in the first 2 years of the policy, and similarly, state employee members saved $2 million in out-of-pocket spending over the same time period. Now, we also have preliminary findings indicating that Oregon's payment cap has had no negative impact on patient experience of care at these hospitals, and no significant changes to hospitals' finances or operational decisions. This is consistent with expectation, as the payment cap affected a small portion of these hospitals' overall revenue. The state employee population made up, on average, about 15% of their commercial patient population. Now, Nevada's proposed legislation could present a similar opportunity to improve healthcare affordability without harming patients and with limited impacts on hospitals. Similar to Oregon's approach, the bill would establish in and out-of-network payment caps for care provided to public employees at large urban hospitals, exempting critical access hospitals and other small and rural hospitals. But the bill proposes to set the cap at 175% of Medicare rates for in-network services and 160% for out-of-network services. Now, I'll note that hospitals in Nevada can break even at an average of 138% of Medicare for commercial payers. And the break even refers to the price as a percent of Medicare rates that commercial payers must pay hospitals in order for the hospital to cover its costs. So the 175% cap still allows these hospitals to generate a margin on their public employee business. This legislation would also allow other public employees, including those from local governments, higher education institutions, and school districts, to opt in. Now, based on data from the Hospital Price Transparency Study and the National Academy for State Health Policy Hospital Cost Tool, colleagues and I estimated that the policy would generate $36 million in annual savings for the Public Employees Benefit Plan. To put this in context, these savings, or from the hospital's perspective, revenue reductions, would represent 1.1% of the $3.3 billion in commercial revenue that the hospitals generated, these specific hospitals that are targeted by the legislation, that they generated in 2022. Further, these hospitals' aggregate commercial operating margins in 2022 were strong at 38%, meaning that for every dollar hospitals earn from commercial payers, they retain 38 cents as profit. So when recalculating their commercial margins, accounting for the $36 million loss in revenue, I estimate that their commercial margins would drop by only 0.7 percentage points to 37.3%. The differences in this bill are unlikely to significantly alter or affect hospitals' ability to operate, patient access, or care quality, as it targets an even smaller portion of hospitals' commercial revenue compared to Oregon's policy. So 3% in Nevada versus 15% in Oregon. Now, I hope this presentation provides helpful insights as you consider potential solutions to rising healthcare spending in Nevada, and I look forward to your questions. Thank you again for having me here today.
Thank you very much, Dr. Murray. David Orentlicker for the record. We're ready for questions. And as I indicated, Celestina Glover's here from PEB, if any of the questions she can help us with.
Thank you. Thank you for the presentation. And I must commend your efforts to say Nevada appropriately well. Good job. Thank you for that. We do have a number of questions. Okay. We do have a number of questions from members. We'll start with Assemblymember Edgeworth.
Thank you, Chair. Thank you, Assemblyman Ornlicker, for bringing this to light. I've certainly heard people talking about how much hospital stays are. My question to you is, are you concerned about a perception there might be that by paying hospitals less, you might be paying staff less when we're kind of short on staff, or that you might be affecting programming that hospitals have, like charitable things that hospitals do? Are you worried about that perception?
David Ortlicker for the record. As we've seen with the healthy profit margins, what we've seen when you reduce costs, that when charges are so high, it just leads to more efficiencies, not to cutting of important services. But Dr. Murray's studied this more than I, so I'll turn to her.
Sure. Rosalind Murray for the record, ROSLYNMURRAY. Thank you for the question. So in the research that we've been conducting in the state of Oregon, we found no evidence that hospitals made any significant changes to their staffing levels as a result of the Oregon policy. So I don't expect that hospitals would respond by cutting staffing in this case. Thank you.
Thank you.
Thank you. Next, we have Assemblymember Gray.
Thank you, Madam Chair. You know, and this is maybe beating a dead horse, but hospital, you know, we're in a free market.
I'm going to interrupt you. We don't beat dead horses. That's not this committee, please. Thank you.
Okay. Maybe chasing a rabbit down a rabbit hole? You know, we are in a free market society. It's still really, I mean, I don't think the hospitals are going to let their margins change. There's going to have to be cuts somewhere, and that will have an effect on the outcome of the patients. How do you propose to ensure that doesn't happen?
I'm happy to take this question. My name is Rosa Murray, for the record. So thank you for your question. The question was related to, you know, how do we ensure that hospitals will be sufficiently supported here and that these cuts will not affect patient care? Again, I'll note my research in the state of Oregon, where we examined patient experience of care at the hospitals that were affected by the legislation in Oregon. We found actually no evidence of changes in patient experience of care, reductions in patient experience of care at those hospitals in the first 3 years after the policy. So there's no evidence that that occurred in the state of Oregon. And in addition, I'll emphasize the point that hospitals, the savings that we've estimated from this policy, 36 million in savings on an annual basis for PEP, it represents about 1% of hospitals' commercial revenue from commercial patient population. So it's a very small percentage of their patient population, and their commercial operating margins are not anticipated to decline very significantly. Thank you.
David Ornlicker, and that's exactly what you would expect from, as I indicated, this is a measure to get us closer to what a free market would look like. We're trying to address the problem that the hospitals are able to exploit their market power and charge more than what a free market would lead us to. So not surprisingly, when you extract their monopoly profits, we don't see any harm to patients.
Another question, please, ma'am?
Go right ahead.
Thank you. So this is not a money question. We're not a money committee. We're a policy committee. But good policy does not pass on costs to counties and local governments. How is that supposed to be covered? A lot of those counties, you know, I'm sure there's going to be pass-ons to those counties, and how's that going to be covered?
Well, I'm David Ornlicker. I'm not sure what costs you're worried about. This bill allows an opt-in for counties so they can get the same savings at the state plan. So this actually should help local budgets as well.
Thank you, Madam Chair.
Thank you. Vice Chair Nguyen.
Thank you, Madam Chair, and I want to thank you for bringing this presentation forward. We talked a lot about it in your presentation as well as Dr. Murray's presentation. since we're talking about a topic, I just want to understand a bit more PEP benefit, and I know that Director Glover is here, so if we could do the phone a friend thing and see if she can go into details of the actual benefits that we would get on these to the public benefit plans. Thank you.
This is Celestina Glover. I am the Executive Officer for the Public Employees Benefits Program. We don't directly contract with the hospitals, so we don't see what their fees are. Our fees are paid according to agreements between our networks and our providers, whether it's a hospital, a doctor, a nurse, whoever it may be. What we don't know is truly what they're charging us. So it may help us. We do know in some cases when we set up one-off agreements for a level of treatment that maybe isn't inside of our plans routinely, we do try to keep that cost down, actually lower than the 175% of Medicare. So we think we would get some benefit, but at this point, without seeing what those agreements look like, which they're reluctant to share with us, I can't guarantee that it's a savings to us, but it may help us stabilize some of our cost.
Follow-up, Chair. So the 38 million that I see on Dr. Olenter's presentation, as well as Dr. Murray, I think she has a slightly different number. That number is not really based on your experience, but is a guesstimate. You would say that, right? And so the actual saving cost may be unknown until this thing goes into effect.
This is Celestina Glover for the record. That's correct. We may get better agreements with some facilities and not as good agreements with other facilities. They're all case by case with our network. So we would need to work with them. As I said, PEB doesn't directly contract with the providers or the facilities, so we don't know what that would look like.
Thank you. Thank you, Director Glover, for coming up and answer the phone a friend. Thank you, Chair.
Thank you. Next question, Assemblymember Hafen.
Thank you, Chair. And thank you, Dr. Ornlicker, for bringing this forward. It's really activated my brain and got me thinking a lot about our healthcare. Our goal as a body, the last few sessions, is to get more people covered by health insurance. And the concern that I'm looking at here is, historically, when we cap fees, whether it's Medicaid cost or what you're proposing here with the PEB caps, is it shifts the burden onto the private sector, right? That means private sector's premiums go up. The hospitals have to, break even, make a profit to keep their doors open. And so they just cost shift. And therefore, when you raise the premiums, that means less families can afford private health insurance. And then it kicks them off, and so now they're not covered any longer because they can't afford it, and so that's the concern that I see. But it did spark my interest, and I do have 3 questions to go along with that. I believe you stated that this would be about 3%, or PEB makes up about 3% of the insurance policy or population that goes to hospitals. But then there was an opt-in for the locals. Do we know what that percentage total might be? And I know it's a hypothetical, but the maximum that it could be, are we looking at the full 15% like Oregon, or somewhere in between?
David Orentlicker, yeah, I don't know. That's something I'll see if I can find out what kind of a range we're talking about. And Dr. Murray, if you want to talk about the cost shifting concern that the Assembly member mentioned.
Sure, I'm happy to address cost shifting and just make a brief point on the number of covered lives. So, we don't have estimates of the total numbers, but we do have estimates for some of the largest educators in the state of Nevada, and including the the educators in the Clark County area, that would be only about 5% of the commercially insured population. So now I'll speak a little bit to cost shifting. So as I mentioned in my presentation, in the state of Oregon, we found no evidence that cost shifting was occurring in the first couple of years. So we did not see any evidence that there was increases in prices for the broader commercially insured population in Oregon at those targeted hospitals. And I'll also note that this is consistent with the broader economics literature that has found that cost shifting does not happen on a large or widespread scale. Thank you.
Going to respectfully disagree with that, but we'll move on to my next question. You had mentioned that the break-even point was 138% of Medicare. And so my question is our state is growing. We continuously see additional hospitals get built. And so when you're defining the break-even, is that including their CIP budgets, their overhead, rent, what have you, or is that just the cost for the particular service, say it's an MRI? And so I'm just trying to determine what break-even under this scenario actually is defined as.
I'm happy to start and take this question. Rosalind Murray for the record. Commercial break-even rates are related to care that is related to providing, it's related to patient care costs. And so it does account for, generally the fact that as the American Hospital Association has stated in many fact sheets that hospitals, Medicare covers about 84% of the underlying cost of providing services to patients, Medicaid around 88%. And so the commercial break-even accounts for the fact that these hospitals are potentially not breaking even or not able to cover the cost for the Medicare or Medicaid patients. Assemblymember Orent-Licker, I don't know if you have any additional comments to add to that.
David Orent-Licker, yeah, if you could just add in the different components when they measure because I believe they do think about not just marginal operating costs, but other kinds of costs.
Yes, Rosalind Murray for the record. Yes, I believe they do account for these other costs that have been mentioned. Thank you.
Thank you. If you could just follow up and confirm that, that would be great. And then my third question dives right into the Medicaid that you just mentioned. So Utah currently is at I think you said the 228%. It's on slide 5 there. And then you had, so the 228 for Utah, and then Arizona and Colorado were both at over 300%. And Nevada is 287%. So my question is, how does the Nevada Medicaid compare to the surrounding states? And I think the big example that you guys have been using is Oregon. And just so I can get an idea of, are these other states doing less than Nevada when it comes to Medicaid reimbursement, or are they doing, like, is Utah? I believe that Utah actually does more in their Medicaid reimbursement, and so I'm just kind of curious how it all will work and how we can compare the examples that you gave in your presentation for Medicare rates, how our Medicaid rates also correspond with those states. And I do appreciate, Chair, the three questions.
David Orent-Licker, I'll start, and Dr. Murray, if you want to add. Same slide, if you go down, we have the break-even point, right? So Nevada's break-even point is below the national average. So that break-even point says, what do you have to charge the commercial payers so you make sure you cover any losses on uninsured Medicaid, Medicare. So we're below the national average. I can get you what break-evens for those other states, but I think that's reassuring. And these data are based on the provider fee assessment with the new funding. It doesn't take into account that because these data are a couple years old. I know that hasn't come in yet, but if that all comes in, then it'll look even better for the hospitals.
Thank you. Thank you, Chair.
Thank you. We do still have a number of questions, so we'll move on to Assemblymember Nadeem.
Thank you, Madam Chair. Thank you, Assembly Member, for the presentation. As we all want to see the healthcare cost reduction and affordable healthcare, that's a very good idea. It's a great idea. But do you think that the hospitals are also suffering because, number one, there are many reasons. Number one is insurance denial, and the second is the medicine cost, the big pharma cost. The medicine cost a lot, and then with the bed, we have the nurses, the doctors, and there's so much procedures going on. So how do you see that? And also the hospitals have to see anybody who doesn't have the insurance, they go to the hospital and they get the treatment. So how are you going to cover all this?
I'll start. David Orentlicker. That's exactly what the break-even point does. It looks at all of these factors that you've mentioned, all of these cost pressures that hospitals face, and they say, based on all of those important factors they face there, what do they need to break even? And so that gets us to the 138%, which again is well below our benchmark of 175%. But, if the hospitals can show us that 138% isn't right, we'll adjust accordingly.
Okay, thank you.
Thank you. Assemblymember Goulding.
Thank you, Chair. Can you, how often are hospital costs recalculated for the sake of setting Medicaid rates? Is that like an annual true-up? Is it something that happens every 5 years? Because we're talking about Medicaid cost, or we're talking about the hospital cost related to the Medicaid rate.
David
I'm happy to
Orentlicker,
start.
I'll turn to you, but did you mean Medicare? Yes, okay.
Thank you so much for the question. Rosalind Murray, for the record. So Medicare, the hospitals report their underlying costs on an annual or even quarterly regular basis to the Medicare cost reports. And there are also audited financial statements that account for hospitals' underlying expenses throughout the year. So it's on an ongoing regular basis.
Thank you. We have one last question from Assemblymember Gray.
Thank you, Madam Chair. Is this on? There we go. With more regulation comes more regulatory oversight, and that burden falls to the hospitals to stay in compliance. What are we going to do to make sure that that's not going to become burdensome on them, and they face all kinds of penalties for it?
David Orentlicker, you mean about the regulatory burden from this bill, or?
Wasn't talking about the one next door, Doc. Yeah, this bill. Sorry.
Well, the nice thing is this is a very simple bill to implement. It just says you can't charge more than X amount. They don't have to go before a commission and submit a request for a rate like Nevada Energy has to do. This is, from a regulatory implementation, about as simple as it can be.
So nobody will be coming in to do audits?
Can I respond to the question?
Yes, please.
Great. Rosalind Murray, for the record. So initial question was the administrative expenses and costs that would be required, or burden that would be required from the hospitals from this legislation. I just want to note that all hospitals are already paid for by Medicare. All of these hospitals that would be subject to the legislation see Medicare patients and receive payments from Medicare. And also a lot of commercial insurers already pay. They also pay on the basis of Medicare. So negotiate, to pay X percent of what Medicare pays. So I would anticipate that this wouldn't be, a massive administrative burden, given that hospitals are already paid based on Medicare rates. And at the same time, in Oregon, the burden really falls on the TPAs or the insurers to ensure that they're in compliance. And so, I would suspect maybe in this case it would be similar. Thank you.
Thank you for the responses. I appreciate that. I'm not seeing any additional questions from our members. We're going to go ahead and move on. So if you will step back from the table at this point, we will now open up testimony in support of Assembly Bill 349. If anyone is here in support of Assembly Bill 349, please come forward and fill in the table at this time. Also in Las Vegas, and there you are. Okay, seeing no movement of anyone in support of this measure, AVH, is there anyone on the telephone line in support of Assembly Bill 349?
If you would like to testify in support of Assembly Bill 349, please press star 9 now to take your place in the queue. Caller with the last 3 digits, 884, please press star 6 to unmute your phone. You may begin.
Good afternoon. My name is Rory Wright, spelled W-R-I-G-H-T. I'm the Chief Operating Officer for Teachers Health Trust. As you may know, the Teachers Health Trust is a nonprofit corporation formed 40 years ago in collaboration with the Union and Clark County School District to deliver affordable benefits to Clark County educators. We cover approximately 18,000 educators and their families with a total membership of 34,000. In our history, we have been acknowledged by physicians and others as the best health plan in Clark County. We did have some struggles starting in 2016 that were not resolved until we brought in our new leadership team in 2021. Since then, we've had 40 plus months of positive margin, improved the benefits, and for the last 2 years have not had to increase educators' premiums. There are several reasons we were able to do this, but most importantly, we obsess about minimizing or eliminating administrative costs, especially those that do not improve access to care or service for educators. That's what brings me here today. We believe that this bill addresses one of the fundamental fractures in healthcare: middlemen making money off negotiating discounts with healthcare providers. The bill establishes a set rate that is fair, covers hospitals' costs plus a reasonable profit, with all the money then going to healthcare and none to a third party. We believe the elimination of third-party payments, vendor services, and anything that doesn't directly improve access or increase benefits to an educator is unnecessary and in reality drives up the cost of healthcare. This is a small but very important first step in our journey to ensure every appropriate dollar goes to the benefit of the educators we serve. Thank you.
Chair, there are no other callers to testify at this time.
Thank you, AVH. At this time, we'll move into opposition. If you are here in opposition of Assembly Bill 349, please come forward and fill in the chairs at this time, both in Las Vegas and Carson City. We'll go ahead and begin in Las Vegas as I see movement down there. Thank you. You may begin. State and spell your name for the record. You have 2 minutes.
Thank you, Chair Brown May and members of the committee. My name is Brian, B-R-I-A-N, Cleven, K-L-E-V-E-N, and I am privileged to serve as the Nevada Market Chief Financial Officer for Dignity Health St. Rose Dominican Hospitals, which is a member of Common Spirit Health. Sorry, I apologize for not being there in person. My schedule did not permit me to make it up there today, but using this lovely facility will testify from here. And I am here to express strong opposition to AB 349, which would cap hospital reimbursement rates at a maximum of 175% of Medicare for public employee benefit programs and other local government health plans. While we understand the need to address healthcare costs, this bill does not do that. It simply caps revenue to the hospitals for these health plans. The bill would jeopardize the financial stability of hospitals and limit patient access to care. Medicare already reimburses well below actual costs in providing care, and further capping rates at a percentage of that is flawed and could potentially force us to cut essential services such as emergency care, maternity, pediatric, and behavioral health and mental health. Hospitals may also be unable to sustain contracts with these health plans, leaving thousands of public employees with fewer healthcare options and choices. This bill would potentially increase travel burdens, especially for those members in rural communities, and lead to delays in healthcare and longer wait times for those members if they had to go to other sites of care. Hospitals struggling financially may be forced to reduce staff, which would contribute to our healthcare workforce shortage. And it could delay or eliminate critical investments needed in healthcare infrastructure and technology, harming both patients and the broader economy. Rather than imposing damaging reimbursement caps to us and just revenue caps, we urge and recommend lawmakers to engage with providers for sustainable solutions that will control costs and maintain high access to quality of care and encourage future investment in the great state of Nevada. For these reasons, I urge the committee to oppose AB 349. Thank you for your time, and thank you for serving as elected officials in Nevada.
Thank you. You may begin here in Carson City.
Good afternoon again. My name is Patrick Kelly. I'm with the Nevada Hospital Association. AB 349 does not offer a solution to the rising cost of insurance. It only exacerbates the problem. Yesterday, we submitted a committee letter outlining the severe underfunding and low reimbursement rates from governmental programs. A few highlights. Hospital Medicaid rates have only increased 5% in the last 22 years. That's not 5% each year for 22 years. It's 5% in 22 years. Medicaid base rates only pay about 53% of the actual cost of care for a Medicaid beneficiary, not the 80% that was discussed a little bit ago. Medicare pays about 82% of the actual cost of care. Medicare and Medicaid patients comprise 75% of our inpatient days, and the uninsured add another 3.5%. Overall, 78.5% of the patients treated in Nevada hospitals pay less than the actual cost of care. That's a huge cost shift. The answer is not to give another group a special hospital rate, and remember, in this bill, it's more than just PEB, much more, and it will create an even larger cost shift. The answer is to have government programs adequately reimburse providers. In 2026, the public option or battle-born plans are scheduled to go in effect. Hospitals will likely receive Medicare rates, further adding to the cost shift. As I testified 2 weeks ago, we're facing the potential for large Medicaid cuts as well. If this legislation passes, it will only shift more costs onto an already small group of individuals, and that's not fair. Hospitals are facing mounting costs related to labor, supplies, and medications. Additionally, we're burdened by significant administrative costs imposed by insurance companies and government regulations. Nevada is ranked by Forbes as 6th in the nation where healthcare is least expensive and 3rd in the nation for the lowest healthcare expenditures per capita. We strongly urge you to read our letter and to vote no on this bill. Thank you.
Good afternoon, Chair Brown May and members of the committee. For the record, my name is Nick Schneider, Director of Government Affairs for the Vegas Chamber. The Chamber is here in opposition to AB 349 today, as we have concerns regarding the price setting of healthcare in such a manner that limits the economic viability of our healthcare facilities. Medicare and Medicaid, as well as uninsured inpatients, comprise more than half of the caseload for these facilities, and the reimbursement is under the cost of treatment. By adding PEB recipients, as well as any local government that elects to participate in this price-setting measure outlined in Section 5, this bill would further place economic strain on working Nevadans by increasing the number of care recipients paying below the billed charge for the service. That added cost would have to be passed along to insured patients, increasing the insurance premiums as well as cost of care. We also have concerns around Section H sub 2 of this bill, as it would allow for an injunction to be issued without any evidence of actual damage being sustained, and further have some concerns about the potential in Section 12 to allow for the suspension, revocation, or denial of a license of a hospital for failing to post on a specific date, as well as tying to U.S. code that could change in the coming days. This bill places further strain on an already strained industry as we work to improve access to healthcare and attract more healthcare practitioners. For these reasons, we are in opposition to the bill and ask thank you for your time and consideration.
Thank you. Is there anyone else here in Carson City in opposition to Assembly Bill 349? Seeing no movement and no one in Las Vegas. AVH, is there anyone on the telephone lines in opposition for Assembly Bill 349?
There are no other callers to testify in opposition at this time.
Thank you. We'll move into neutral testimony. Is there anyone here wishing to offer testimony in neutral on Assembly Bill 349? Please come forward. Seeing no movement and no one in Las Vegas, AVH, we will once again check the telephone lines. Is there anyone here in neutral on Assembly Bill 349?
The public lines are open and working, and there are no other callers at this time.
Thank you, AVH. At this time, we'll invite our bill sponsor back up if you would like to make closing comments.
Thank you, David Orntlicker. Dr. Murray, would you like to start, and then I'll wrap up?
Happy to go first. For the record, my name is Rosalind Murray, SLYNMURRAY. Thank you, Madam Chair and Vice Chair and committee members, for the opportunity to provide some concluding remarks. I'd like to take a moment to address some of the comments and concerns that have been raised during the testimony. As I mentioned earlier, rising hospital prices have been identified as a primary driver of increasing healthcare spending in the United States, contributing to higher premiums and financial burdens for U.S. individuals and families. The state of Oregon addressed this issue by capping hospital prices for care provided to state employees. Again, I'll emphasize that this legislation places an upper limit on prices, benchmarking Medicare, not suggesting that Medicare is a price endpoint. It allows negotiations to occur under the payment limits that are being suggested. Through independent evaluations of the policy, Oregon's policy, colleagues and I found that it has successfully limited price growth without negatively affecting access to care, quality of services provided. Additionally, there was no evidence of cost shifting to other payers in Oregon, which aligns with the broader economics literature that generally shows cost shifting is not widespread. The policy has not impaired hospitals' ability to operate, and there were no cuts to essential services, and has helped to control costs for both the state employees and the state budget. Based on Oregon's experience, Nevada could achieve similar outcomes with AB 349. My estimates suggest that if the policy were applied to public employees alone, it could save about $36 million on an annual basis, with the potential for larger savings if other state plans opt in. The expected impact on hospitals would be modest, representing 1% of their total commercial revenue and a small reduction in their commercial margins, less than 1 percentage point. It is also important to note that while hospitals may face Medicaid payment cuts, large hospital systems, those that would be subject to the legislation, are less likely to be significantly impacted, as they typically have sizable reserves and a smaller Medicaid payer mix. The stress is likely to affect safety net hospitals, which are exempt from the policy, as they rely more heavily on Medicaid and operate on tighter budgets. Additionally, states are facing potential federal funding cuts, so managing resources effectively is crucial. AB 349 presents an opportunity to improve healthcare affordability without compromising access to care or hospital financial stability. And while hospitals may experience some revenue reductions, the overall impact will be modest compared to the long-term savings and broader affordability benefits for patients in the state. Thank you again for the time. For your time and for allowing me to address these important points. And I'm happy to answer further questions or follow up later on after the hearing. Thank you so much.
Thank you, Dr. Murray, and thank you for allowing us to present. We've heard from the opposition some potential things that may happen. And what we know is we have data that tell us whether they will happen. And the data from Oregon are very clear that what a bill like this does is just counteracts the monopoly power of hospitals. It doesn't take away money they need. It hasn't in Oregon. Montana had a policy like this for a period. It didn't happen in Montana. And what's important in both Montana and Oregon, have largely rural areas, just like we do. We're drawing on experience that from states that are like us in important ways. So, yes, we have to make sure we're not going to cause problems, and we know from the data that this will only reduce the monopoly profits of the hospitals while protecting patients from any harm because they're earning more money than they need. That's why the Medicare gathers all their cost data. So thank you very much for your consideration, and I'll follow up on the questions where we didn't have the answers.
Thank you. At this time, we will close the bill hearing on Assembly Bill 349. That moves us to our last order of business. Anyone wishing to provide public comment in the room is welcome to come forward at this time. To provide public comment or testimony over the telephone line, please dial 888-475-4499, and then when prompted, to provide the meeting ID at 882-2054-2738, and then press the pound sign. If you are here to offer public comment, please state and spell your name for the record, and you have 2 minutes. You may begin.
Good afternoon, Chair Brown-May and members of the Assembly Health and Human Services Committee. My name is Isabella Tran, that is Isabellatran. I am here not only as a policy intern at the University of Nevada Larson Institute of Health Impact, but also as a concerned friend and sibling who has witnessed firsthand the devastating impacts of our state's youth mental health crisis. I could rattle off statistics like how 1 in 5 teens experience at least one major depressive episode, yet 60% receive no treatment, or how the economic burden of untreated mental health disorders in the U.S., including healthcare costs, lost productivity, and criminal justice expenditures, exceeds more than $200 billion annually. But I didn't miss school to lecture you all about numbers. I came here to share my personal experience supporting family and friends who have struggled with mental health and to urge action. I am someone who likes to plan things far into the future, but so when my sibling told me that they didn't know what they wanted to do in the future, I thought little of it because many of my friends were uncertain about what they wanted to do in the future also. But my sibling didn't avoid planning for the future because they didn't know what they wanted to do. They avoided it because they did not see a future for themselves. They were diagnosed with depression 2 years ago, though in hindsight, that diagnosis came far too late. They have attempted suicide multiple times and have struggled with suicidal thoughts even more often. And when those moments of crisis arise, they always seem to fall in between scheduled therapy appointments. The only immediate option for care is the emergency room, a place we know we will wait for hours, only to be told that there aren't enough inpatient beds available in Reno. Knowing this, my family has opted not to go at all. This is the reality for so many of my family and friends here in Nevada. According to the 2024 State of Mental Health in America report from the nonprofit Mental Health America, Nevada ranks 51st in the nation for overall mental health, and it has some of the highest rates of youth struggling with mental health challenges. Suicide is the second leading cause of death among individuals aged 10 to 24, and rates have increased nearly 60% over the last decade. We cannot allow this crisis to continue. We need policy solutions that expand access to care, improve early intervention, and strengthen Nevada's mental health infrastructure. Thank you for the opportunity to testify.
Thank you. Thank you for sharing your story and for coming forward today. Is there anyone else in the room who would like to offer public comment at this time? Seeing no movement and no one in Las Vegas, AVH, is there anyone on the telephone line that would like to offer public comment?
Public line is open and working. There are no callers at this time.
Thank you, AVH. I'd like to thank you members for your time and attention today. I know it was a long day, very troubled with the gremlins in the system. Our next meeting is Friday, March 14. Note on your time on your agenda is at call of the chair, so we will ask for your flexibility, but your offices and you will be notified. Thank you. With that, this meeting is adjourned.